Hi, everyone. Welcome to our second Q&A. Just a little bit of housekeeping and updates before we get started. We'll be hosting these Q&As every month, and the recordings will always be uploaded to our YouTube channel. The best way to know when they're uploaded is to subscribe to the channel, and feel free to throw in a like or a comment on the videos that you watch. We're always really excited to engage with you guys on our socials. On that note, we will also be announcing some pretty big news for our people here in the US in the next couple of weeks. So if you've not done so already, go ahead and create an account with us on outro.com to sign up for those updates via the newsletter. We'll also be sharing clips from our webinars and those same important announcements across our socials. It's at Outro Health, and that's us on Instagram, on TikTok, on X, and you can kind of find us there, which would be great. On our Luma, which is how you guys subscribe to this webinar and we're able to submit those questions, we also have posted a couple of other webinars that are coming up. We have an exciting one with Angie Peacock. We also have one with Dr. Adam Muratu, who will be specialized in commenting on women's health and pregnancy. And you guys can also be submitting your Q&As for him, which would be great. And then also with Dr. Uma Naido on lifestyle medicine. Mark, if you want to introduce yourself.
So my name's Mark Horowitz. I'm a training psychiatrist and researcher. I work in the UK in the National Health Service, and I'm also one of the co-founders of Outro, and I help to supervise the clinical team there. And all of my research and practice is in how to safely stop psychiatric drugs, including antidepressants. And that's what I'll be talking about mostly, I guess, this afternoon.
The question here, the first one is, did you feel like you failed when you relapsed and then reinstated?
So I guess interesting choice of words there. I don't think I relapsed. Relapse is sort of the word people use for a return of depression or anxiety. I don't think that's what happened to me. I had very severe withdrawal effects from the drugs. Did I feel like a failure? I guess no. I mean, it was very up. It was that thought is so benign compared to the severity of the symptoms that I had, that thinking that I was a failure was sort of not on the top 50 thoughts in my head. The main thought was, oh my God, am I going to die? So failure wasn't a big feature there. So I sort of understood fairly quickly that what I was going through was withdrawal, not a relapse. As I think I said before, I went on these drugs when I was an unhappy young man. I didn't have a relapse of being an unhappy young man, not sure what I wanted to do with my career. I had I had essentially what was mild to moderate akathisia and panic attacks and trouble sleeping. So I kind of understood. It was very disturbing, as I say, but I understood that it was withdrawal. And I think I even understood fairly quickly, because I had read so many forums, that what I needed to do was to come off the drug more slowly in the future. So I guess it was it sounds very benign to call it a learning process, but I guess in retrospect it was.
Yeah, definitely. And a question maybe about your experience as a clinician. How do you make small taper dose adjustments feel like an achievement? How do you help patients celebrate those wins?
Look, I think it's a lot about setting expectations. So if you come in with the expectation it'll take you 2 weeks or 4 weeks to come off your drug, then I think you're going to find the whole process very frustrating, and very hard to put up with. So I think I went through a process myself of adjusting my expectations. I thought, first of all, that coming off over 3 or 4 months was very slow. And as I said, I almost died coming off in 3 or 4 months. So I learned that was not slow. And from that, I thought, then going off over 9 or 12 months, that's very slow. That was very hard. I thought, 2 years is very slow. And, in the end, it took me years to come off my drugs. Again, I don't mean that's true for everybody listening to this. Of course, it's not. I was on many drugs. I made many mistakes. There are lots of people that can come off in a few months. But I guess, it's about setting expectations for how long things will take. So by the end, I was very pleased every time I went down by 0.01 milligrams of my drug, because I could see it was going in the right direction. It was fairly comfortable. Yes, I think like a lot of people, I spent a lot of time on spreadsheets going, how long will this take me if I keep on doing it this way? And of course, I'd be lying if I wasn't very upset at how long it took, and I wish it had been faster. I guess I learned patience, and I learned about the process going through it. I think so now that you sort of use this phrase, I think I was very happy with every reduction, because I knew I was getting somewhere. How do I convey that to others? I think you've got to see it as a process, all these cliches. The quickest way to come off these drugs, it was said to me, and I think it's very true, is slowly. That's what I learned, that coming off quickly ends up in a lot of pain, go back on the drugs. And so the only way off is slowly. So I I think people do learn that as they go through the process and make errors often.
Well said. Just throwing it back a couple more years. When did you know you were ready to taper?
I always find this question, a bit hard to answer. I came off at rock bottom in my life. So, I guess the sort of polite answer is, it's good to come off if you feel stable. I think that's true. It's easier to come off things if you're stable, but I don't know that you have to be stable to come off the drugs. So I was in a very bad way because I was on a lot of drugs, psychiatric drugs. I was very tired all the time. I had major trouble with memory and concentration. That affected my work in a very big way. So I was working part-time. It affected my social life because being so tired and basically incompetent at that point, really affected my self-esteem. So I was extremely miserable. I think that being on the drugs in retrospect made me much more depressed, much more anxious, and much more emotionally labile than I am now off the drugs. So when I came off the drugs, I was in a really, really bad way. No one would have called me stable. So I guess, it's still true to say, yes, it's better to come off the drugs if you're stable. If you're in and out of hospital, it's probably very hard to come off the drugs because you're already extremely unstable. I wasn't in and out of hospital unstable. I was just, barely holding on to my job, barely kind of functioning socially unstable. And I think that if I hadn't come off my drugs, I would have been in a much worse situation than I am now. I'm giving a bit of a mixed answer there. Good to be as stable as you can be, but I'm not sure you have to be completely stable if you do it slowly. That's the other thing, I guess. If you rush off your drugs, doesn't matter how stable you are, you're going to get into trouble. And I think to some degree, you come off very, very slowly, which means, more than a year, sometimes many years, maybe it doesn't matter that much how unstable you are.
That's well said. I think it's pretty relatable to a lot of the people in the audience, myself included, that when you realize that maybe it is time to get off your medication, you actually are experiencing quite significant amount of burden from the side effects from the medication themselves. So to say that you need to be stable in order to start is almost catch-22 because how could you define stability within the confines of the side effects that you're experiencing on the medication? Very
Exactly.
true.
Yeah, well said.
Now moving on, just because last time we were only able to cover like 3 of 10 sections, I'm going to move on to a couple of miscellaneous questions that I thought were interesting myself, and then I'm really excited to hear your answer to. What are 3 articles, or it doesn't have to be 3, but do you have a couple of articles that you suggest that a patient might print or send over to their primary care doctor to help communicate, what it is that they're going through and how to best facilitate the taper process?
Okay. So I think this is a very important question about lived experience. And I mean the lived experience of being a doctor. Doctors in general, and so I think there's a lot of anger towards doctors, which I understand and I share in lots of respects. Doctors are overworked, they're running from patient to patient, they're reading, dozens of things. I think doctors don't love to be handed a thick, pile of papers and being told to read it. If that happened to me as a doctor, I probably would be thinking, I just want to get home. I just want to put my feet up and have
personal experience.
Yeah, I definitely am. I just want to get home. I want to, I don't know, watch TV, stop thinking. So I suggest you bring one article in if you bring an article, or send one link so you don't overwhelm people. If they're interested and they talk about it, okay, send one more. So I think number one is, minimalism works here. Make it easy for them. If I had to choose one, it'll sound very conceited of me, but I think the Lancet Psychiatry article on safe tapering, everyone knows what the Lancet means, so it brings a bit of authority to it. That's not a bad one from 2019. Maybe something from the Royal College of Psychiatrists, fairly long handout, but again, that's a very recognizable, authoritative brand. That guide, I think those are the 2 that I recommend to people the most. Sometimes people want to convey that their symptoms of protracted withdrawal are from protracted withdrawal. And then I normally recommend people bring in a paper by Cozzi and Chouinard, I don't know if I'm pronouncing that correctly, from 2020, that lists all the different symptoms of protracted withdrawal from different psychiatric drugs. And then they can almost circle it, show it to their doctor, look, you think that I've got some bizarre illness, but actually it's all in this paper. So those are probably the 3 papers that I recommend to people the most.
Okay, that was great. And then for anyone in the chat who's asking for them, in the follow-up email, when we send out the link to the recording on YouTube, I'll also just include these references so that anyone can access them. Because I know that, it's a lot of multitasking going on here, and I don't want anyone to be worried about not being able to type in as quickly as Mark speaks. So the next question is, I really like this one. We say emotional numbing is an unwanted side effect from antidepressants, but some people often comment that numbing is the whole point. Can we talk about what we mean when we say we're talking about emotional numbing as an unwanted side effect?
Fair question. I mean, I guess let's take a step back. This comes to this sort of general question of how do antidepressants and other psychiatric drugs work? And I probably talked about it before, but there's 2 kind of answers that are given. One is these drugs do something that fixes an underlying chemical imbalance. They're affecting serotonin, or they're affecting norepinephrine or dopamine, or they're affecting inflammation or cortisol. There's this idea that the drugs are kind of fixing an underlying problem that causes mental health problems. And very briefly here, research doesn't really back up that there are clear biochemical problems that underlie things like anxiety or depression. They're very common experiences. They're predicted by the number of stressful life events people experience. People's personality affects them, of course. There's probably a bit of a genetic component in people's personality especially, but there's no simple biochemical, low serotonin or low norepinephrine. And so the question comes, how do these drugs work? And in surveys that have been done, most people on antidepressants say they feel emotionally numbed. What they mean is the range of emotions from very positive to very negative have been squished into the middle. And I get why this person's saying, that's the whole point. Some people find that beneficial. If you've got anxiety and panic and low mood, that's 10 out of 10. Turning the dial down to 3 out of 10 can be a big relief. So I understand that. I do think that's different from a drug affecting the underlying chemical imbalance causing it. Sort of the drug's effects are being superimposed on top of the feelings. They haven't solved them. And so it's a very different explanation to being told that the drug fixes a chemical imbalance. So I think, first of all, people should be aware of that. That's probably the way these drugs work. I think lots of people would still use them. I think that's a legitimate choice to make, but it is a different explanation to that it's fixing underlying chemical imbalance. It might make you think it's might be not something you do long term. It might be, you might look for other solutions at the same time. I think it's important to realize. And then this question, how is it an unwanted side effect? So I guess there's a big debate. What's a side effect? What's an effect? Some people say, look, there's just effects. The drug company wants certain effects because that's how they want to market it, but there's just effects. You take a drug, it affects your body. It's sexual, impairment, weight gain, emotional numbing. It depends, what your point of view is, if that's wanted or unwanted. I guess where it becomes unwanted is, obviously, it doesn't just affect the negative side of the equation, it also affects positive emotion. So people often say they don't feel love as much, they don't feel enthusiasm, they don't feel interest or happiness, and that's where it becomes unwanted. So one of the main reasons people come to see me in the clinic that I run in London is they say, I don't know who I am anymore. I don't sure how I feel about my spouse, my children. I used to like sport or art or music, and now I'm not interested. And I think it's because of the drug. And that's where the emotional numbing that might have been welcome, as the questioner says at the beginning, becomes aversive or has a negative effect on their lives. And they often say, I want to know who I am, is a big kind of underlying aspect of that.
Yeah. I think just to point on that, it's almost, I sometimes also like to think of it as more than emotional numbing. It's a numbing that's holonic. It takes over the elements of, like you said, who you are. I think the things that you used to enjoy doing, you might no longer enjoy, or you don't know how to enjoy them, or you don't know what you enjoy. I think something too that I've heard from our patients at Outro is, after 10 years of being on a medication, like you said, maybe symptoms were at a 10 out of 10 when they started, but 10 years later, the symptoms themselves have been mitigated and there's just a lackluster. Grass doesn't seem as green, and, maybe they want to be celebrating wins and they don't feel that same joy for celebration. It's not just numbing of the negative emotions. It can be numbing of everything.
Yeah. Actually, I'll just add 2 points. Agree with that, Emma. Sometimes people miss negative emotions too. I should say, people say to me, a classic line is, I didn't cry at my grandmother's funeral, or I didn't cry, and that seems to me to be an abnormal thing because negative emotions are a part of life. So not just the positive things. I'll just add one other thing. The emotional blunting correlates with sexual blunting as well. So that seems to be matched. And also, because I deal with a lot of liquid versions of these drugs, if you crush up antidepressants and swish them around your mouth, it often numbs your mouth. So there's definitely a kind of anesthetic property to these drugs that's a core part of what they do.
Why don't we know more about the safety of antidepressants for pregnant women? Why is there so little research on the topic?
So I think there's two things to say about that. Number one, we do know quite a bit from lots of observational studies, but the main reason is there's no randomized controlled trials in pregnant women. And the reason for that is they say it's unethical to do studies in pregnant women whether they're randomized to antidepressants or not. And I don't think that's true. There's two ways to look at it. I would say it's unethical to give women antidepressants without there being randomized controlled trials, because a randomized controlled trial, the reason why people might say it's unethical is they'd say, well, it's unfair to give a woman a placebo because antidepressants are so effective. And so it's unethical to give them no treatment. But because it's not clear that antidepressants are that effective in pregnancy, I don't think it's clear to say that it's unethical to give a placebo. So what's happening is millions of women around the world are being given a drug that hasn't been tested in them. So that's why there's uncertainty. There's a few issues with the existing research. So sometimes people say, women during pregnancy should stay on antidepressants. And the reason why they say that is because there are studies in which women have been stopped on antidepressants in pregnancy and they've gotten worse. And if people have heard me talk about this before, that's the way they do these studies is they get people on antidepressants, pregnant women, and they randomize them to either continue or to stop their drugs. And they use depression scales to see who gets worse, and the women who stop get worse. Well, they don't measure withdrawal effects. And of course, as people in the audience will know, people get anxiety, low mood, panic attacks, crying. If you don't look out for that, particularly as a withdrawal effect, you would think that everyone who stops gets worse. And my analogy is, if you took people who smoked cigarettes and stopped half of them smoking, they'd get anxious and irritable. And if you didn't think about withdrawal, you might say, well, people should continue smoking to prevent anxiety and irritability, which would be, of course, a ridiculous thing to say. But the point is, if you don't pay attention to withdrawal effects, you can come to quite perverse conclusions about the results of these studies. So I don't think there's very good evidence to say that taking antidepressants during pregnancy prevents depression. That's the first issue. And then there's what are the harms? It's a longer conversation, but there's lots of harms that are found in observational studies where they look at people who are on antidepressants or not. They try to control for depression as much as they can, and they look for the risk to the baby and obstetric risks, risk to the mother. And they find in lots of studies that many of these issues are increased in the people that take antidepressants. So I think the question is right. There's not perfect knowledge, but I think there's enough information around that people should be concerned about taking antidepressants unless there's no other option.
Very well said. I was actually speaking with a woman very recently, and she has one child, and she had difficulty in the delivery of her child, and she was on citalopram. And she believes, after due research, that the reason that she experienced those birth difficulties was actually because she was on the antidepressant, and now she's afraid of giving birth again. So it's actually what deterred her from growing her family. There's so much more to address there, and I just want to hold space for everyone that did submit those questions. They will be addressed next month. And we're going to move on now to the section of tapering approaches. One that I always think is fun to hear, because you covered this in the last Q&A as well, is can we do a compare and contrast between hyperbolic tapering, micro tapering, and linear tapering for everyone here in the chat, just to get a better understanding of the different tapering approaches?
So this is where I sort of bring up a graph. Let me tell you what you're looking at, and then I'll try to make sense of what linear versus hyperbolic tapering is, and then I'll talk about micro tapering after that. So this is a graph that shows on the x-axis dose of venlafaxine, and this is 37.5 milligrams here, the smallest capsule, 75, 112.5, 150, etc. And on the y-axis, it's basically effect on the brain. It happens to be the blocking of the serotonin transporter, that kind of the key action of these drugs. But you can think about it just as effect on the brain. And the main point is that it's not a straight line relationship. Doubling the dose of venlafaxine from, say, 75 to 150 doesn't double the effect on the brain. In fact, it doesn't have that big an effect at all. And a tiny dose, like 5, so this is 50, 40, 30, 20, 10 milligrams, which sort of sounds like a tiny little dose, actually has 2/3 the effect of 300 milligrams, much bigger than you would expect. And the reason for this curve shape, the technical term is the law of mass action. And what that means in simple terms is when there's not much drug in the brain, all the receptors for the drug, that's the bit where, sort of the bit on the brain where the drug kind of has an effect. If you've ever heard like a lock and a key, it's where like the keys of venlafaxine click into the lock in the brain. Because all the locks are unoccupied, every milligram of drug has a very large effect. A bit like the game of musical chairs at the beginning of the game, it's easy to find a chair. As there's more and more drug in the system, more and more of these receptors are filled up by venlafaxine or Effexor. And so every extra bit of drug has less and less effect. You get this sort of law of diminishing returns. It's hard for these final milligrams to find any locks, receptors to kind of click into. And that allows you to understand what linear tapering achieves. So linear tapering is you're on 150 milligrams of Effexor, and the doctor says, let's drop it by 37.5 milligrams every week or two. You'll go down to 112.5, 75, 37.5, and then 0. And it sounds pretty good because it's simple with the capsules. They come as 37.5 milligrams. It sounds like it's evenly spaced. The problem is, if you now look at the y-axis, the effect on the brain is very different for every step. The first step probably is not that bad. Some people find that already a bit unpleasant, but a lot of people find that fine. The next step is a bigger reduction in effect. The next step is bigger again. And the last step is like jumping off a cliff. You know, the going from 37.5 milligrams of venlafaxine to 0 has about 40 times the effect of going from 150 to 112.5. And so linear tapering, going about the same dose every week or month, tends to cause people increasing problems as they get down to lower doses. So hyperbolic tapering instead is, rather than going down by even amounts of dose, it's going down by even amounts of effect on the brain. It's probably a bit hard to see this because the curve is so steep, but I've drawn basically 4 horizontal lines in this sort of dotted yellow vomit color that go horizontally, and they correspond to about 150 milligrams and then tiny doses all the way down to a very, very small dose. And so that's what hyperbolic tapering is. Because this shape is called a hyperbola, this is called hyperbolic tapering. If you imagine walking down, imagine this was a sort of a path, imagine walking down this. It's first of all very easy at higher doses. It gets steeper and steeper. So you got to be more and more careful as you get down to lower doses. And so hyperbolic tapering means slowing down as you get to lower doses. And you go down to these tiny doses, much smaller than commonly available capsules or tablets. And what I've just shown you for venlafaxine or Effexor is true for every antidepressant, actually every psychiatric drug, known to man. They all have this same curve. So that's the difference between linear and hyperbolic tapering. And all micro tapering is basically taking reductions you might make so let's say you're on 150 milligrams of venlafaxine, and the first month you go down by 10%. So you go down from 150 to 135 milligrams. So you go down by 15 milligrams. The micro tapering equivalent of that would be to break that into smaller steps. So rather than one big jump from 150 to 135, you might break it into 4 jumps of 4 milligrams each week. That would be a micro taper done weekly, or the kind of most micro taper you can do is doing it daily. And so rather than doing 15 milligrams over 30 days, you would do 0.5 milligrams every day. So 30 little jumps of 0.5 milligrams. So the same total reduction in all those situations, about 15 milligrams a month, but breaking into little tinier steps. And the reason why you might do that is because it makes it a bit easier on the brain to make smaller reductions more often than one big jump in one go.
And just one question that I too have about the micro tapering approach as well. Do you think at times it could be difficult to be doing a micro taper and then experiencing an uptick in, the burden of withdrawal symptoms, and then being able to identify what the dose was, go back to minimize those withdrawal symptoms?
It might be, but because you're kind of making the same reduction each month, it shouldn't be that much more complicated than if you'd made one big jump, because it's sort of the same kind of changes broken up. But yes, some people kind of interpret it like that.
And then the next question here is, can you explain what a cross taper is and when you do it? And that was by Heidi.
The short answer is basically never. So sometimes people are switching drugs because their doctor thinks they should be on a different drug. The other reason is some people cross taper from a shorter acting drug to a longer acting drug. And so when people are talking about antidepressants, they're normally talking about cross tapering from a short acting drug like Paxil or Effexor to a longer acting drug like Prozac. And the reason why I'm not very keen on that is it doesn't work very well, and it's not that easy to come off Prozac. So we don't generally do that at Outro, because the switching from one drug to another drug is often very tricky. It looks very easy in textbooks, but in practice it's often very hard. And Prozac, has been described by its manufacturer as self-tapering. You can just stop it. And that's total nonsense. It causes withdrawal effects almost as often as other drugs, other antidepressants cause withdrawal effects. It's just often delayed, so it can take a few weeks for them to kick in. The way that the drug company did that study to trick everybody was it only looked at symptoms for a week, even though it takes Prozac a few weeks to leave the blood. So they were never going to see any withdrawal effects within a week. And because of that big study they did a couple of them, it sort of entered the textbooks that this drug is very easy to stop. There's no withdrawal effects. But if they'd done the study a few weeks longer, they would have seen awful withdrawal effects. So it's often called the Prozac bridge. And I sometimes jest that it's the Prozac bridge to nowhere, because often people find it hard to switch and they often end up on both drugs. Or if they manage to get across to Prozac, it's often hard to come off. So I think the simplest way to come off an antidepressant is to come off the drug that you're already on. You're already used to it. There's no surprises, and just to do that slowly. So I'm not very keen on cross-tapering.
And the next question is, if a person's on polypharmacy or multiple antidepressants, is there an order to which to taper first, or is it a case by case?
There's a few different things to think through. There's to think about which drug is doing the most harm and the least benefit, and start with that one. And sometimes people will say, look, I know this drug is awful. It's maybe put on weight, or I can't think straight on this drug. I want to get off this one. That's a very good reason to come off that drug. The second way to look at things is which is the easiest drug to come off. If someone's on 5 drugs, there's a victory to being on 4 drugs. And so for a quick win, it's nicer to come off a drug that's easier to come off. And that often means the drug that people have started most recently. So in last in, first out. A drug you've been on for a few weeks or just a few months is often easier to stop than one you've been on for years or decades. Some drugs do have a lower risk of withdrawal than other drugs. So a good example would be something like bupropion is easier to stop than most other antidepressants. And so you might want to start with that just to kind of give the person confidence that what they're doing is okay. If there was no obvious candidates from those kind of thoughts, you might choose the drug that's got the most objective negative effects, something that puts on weight or causes other serious physical problems. And then there's a debate about whether you should keep on drugs that kind of help you to sleep and save them for last. And there's different views on that. And sometimes that can make sense.
That actually follows up into my next question here, which is, my doctor recommended that I begin a low dose of trazodone to help me with a clonazepam taper. Is that a recommended strategy, or am I setting myself up for a future problem by adding trazodone?
The second bit, you're setting yourself up for a future problem. So, the first step to coming off drugs is not to use more drugs. So, I know that sort of sounds a bit glib, but if you use other drugs to come off a drug, you're not stopping drugs, you're switching drugs. So it's a bit like coming off whiskey by drinking vodka. Maybe vodka is better than whiskey for some reason, but essentially you're still on something. So trazodone is a dependence-forming drug like clonazepam is. You could argue that trazodone is safer than clonazepam potentially, which might be true, but then you're switching drugs rather than stopping them. So the best way to come off any psychiatric drug is to come off slowly enough that doesn't cause you huge trouble, so you don't need to use other drugs. If you're starting to have trouble, rather than adding a drug in, it's better to come off more slowly. I'll give you a quick analogy because this comes up all the time. Coming off psychiatric drugs is a bit like climbing mountains, even though it's the opposite direction. There's a thing called altitude sickness people get if you go up a mountain too quickly. Because if you go up a mountain too quickly, the pressure drops and your body can't handle it and you get dizzy and headache and you feel terrible. And the best way to manage altitude sickness is to stay where you are and wait to get used to the altitude, or even go back down the mountain and then come up more slowly. Same as coming off psychiatric drugs. So if you saw someone who's climbing a mountain and they started to feel really sick and they started to take trazodone or clonazepam to manage their symptoms, you'd be thinking, and they kept on going up the mountain, you'd be thinking they're going to get into more and more trouble. They're not actually fixing the problem. They're actually going to perpetuate the problem, and they're adding on more drugs. So I think the same applies to coming off psychiatric drugs. If you're having trouble, slow down, take the message. Withdrawal effects are a message from your system that you're going too quickly, and covering them up with other drugs, one, misses the message, and two, exactly as the questioner has said, means you're going to have more trouble down the track coming off that drug.
I just want to follow up and ask, When you say drugs, you're also talking about supplements.
Yes. I mean, so it's another long discussion. I mean, supplements, yes, I think there's some broad similarities there. People always want to know, can I kind of come off quicker if I use supplements? And
Hmm.
I think the answer to that is essentially no. That the process of coming off the drugs is your brain readapting to the drugs not being there. That involves whatever changes the drugs cause to your brain reversing. If the drugs cause your serotonin receptors become less sensitive, like a lot of antidepressants do, then coming off them involves your receptors becoming more sensitive to them. Supplements cannot poke the brain to do that more quickly. I think an analogy is if you break your leg, there's a very complicated process of your leg healing. Old bone cells are being removed, new vessels are being grown. There's no supplement that can make your body do that thing more quickly because it's an evolutionary process, that's very complicated. Same if you cut your skin, there's no supplement you can take to make it happen more quickly. And I think the same is true for your nervous system responding to the drugs being removed. I don't think there's any herb or supplement or drug that can make that happen more quickly. But I think there are things that can disturb the process because some supplements are actually very similar to psychiatric drugs. In the same way that St. John's wort is essentially a natural version of antidepressants, a lot of supplements, affect GABA, affect serotonin. They're kind of natural versions of psychiatric drugs. So I tell you, the most alarming thing that I hear people say is if they say to me, I've tried a new supplement and it makes me feel very calm and relaxed and sleep well. That sends off alarm bells in my mind because, if a psychiatric drug did that, of course, the same things will happen. You'll get tolerant to the drug over time. You'll get withdrawal effects when you stop it. And it's probably going to cause some sort of toxic effects in the long term. So just because something is, from a flower or a herb, it's probably less potent. If I was at, gunpoint, I'd probably take a supplement over a drug, but I don't think it's free of risks. So I would be very cautious with supplements in withdrawal.
It's still a chemical that has an effect on your nervous system.
Exactly. And I sort of say there's no free lunch when it comes to chemicals in the brain. That would be my summary of a decade of research.
Fair enough. And I just want to recap, and because we got questions in the Q&A and in people that registered for the event, that does include melatonin.
I mean, I should say, there is, I think there's more benign things. So I gave you the tough guy answer. Look, I think there are things that are basically harmless. I think fish oil, I've never heard anyone having serious trouble with fish oil. It can cause, burps. I think prebiotics, are pretty harmless. I'm just sort of saying, there's not, I think, most vitamins don't cause major troubles. Occasionally someone says that vitamin Bs are activating. I do think melatonin is more on the benign side of things. I don't want to say everything, it's totally safe, but I haven't heard people say to me they've had serious trouble stopping melatonin. So I don't want to say it's completely benign, but it probably is over the more benign side of things. I was about to say people often use it at very high doses, especially in America. So the most effective dose for melatonin in studies is 0.3 milligrams taken a few hours before sleep because it helps people's circadian rhythms. But in America, people take 5 or 10 milligrams as a sleeping tablet. And that actually, the evidence is actually not very strong for it. It's much better at making you sleepy if you take it a few hours before bed than just before bed.
You mentioned St. John's wort as a supplement people should not be taking, especially while they're tapering. Is there anything else other than St. John's wort that you'd like as like a quick shout out to avoid?
Good question, Emma. Any supplement that has the same chemicals that psychiatric drugs have in its name would be one to avoid. So anything that's a GABA supplement, anything that's a serotonin supplement, that means 5-HTP, those are literally trying to do the same thing. Benzodiazepines act on GABA and antidepressants mostly act on serotonin. So anything that has that, if a supplement says that it increases or acts on that, it's essentially a homegrown version of a psychiatric drug. Those would be the ones that I would avoid like the plague.
First question for the withdrawal symptom section. What should I do if the antidepressant for sleep, mirtazapine, is no longer working? When I try to stop, I can't sleep at all.
So I guess that's sort of the classic, issue that arises with psychiatric drugs. So you're talking about the two elements of dependence on a drug, tolerance and withdrawal. So it happens, basically what this person's describing is what happens to almost everybody. So you take a drug like mirtazapine and it helps you to sleep, makes you calm. And over time, your body reacts against the drug and it becomes less and less effective. It causes tolerance, like caffeine or opioids or any drug that we take. That's the sort of natural process of homeostasis. We try to act against changes to our body. And that means over time, you either need to take more of the drug or the drug has less effect, and that's tolerance. And the flip side of tolerance is withdrawal. If you become tolerant to a drug, that means your body's gotten used to it. And when you remove it, your body is screaming out for the drug to come back. And the most common withdrawal effect from mirtazapine is insomnia. And so now you're kind of in this classic trap. The drug's not working anymore, so you're tolerant to it. And when you try to stop it, you get withdrawal effects, so you're sort of trapped on it. And so there's a couple of options there. One, you can increase the dose and repeat the same process. That means that you're going to double the dose or increase it by 50%, hope that it keeps working now for a bit longer. And over time, again, it'll wear off because to some degree, all of these drugs are a bit like quicksand. Their effects all diminish over time because that's what tolerance does. So you could try to buy some more time by going up on your dose. Or the other option is rather than stopping it abruptly, because you sound like you've stopped it, all in one go, and that's why you've got terrible withdrawal, would be to stop it more slowly so that you get much less withdrawal that you can handle. And so rather than stopping it in a day or a week or 4 weeks, you might stop it over several months or longer. The idea being that, rather than you've sort of jumped off a building to come off the drug, but if you walk down the stairs more slowly, it's not so disruptive to your system. And so you minimize, or back to the altitude sickness example, rather than rushing up the mountain and feeling really unwell, in this case having trouble sleeping, you go up the mountain much more slowly. And so you come off the drug in a much slower way that doesn't cause the same level of disruption. Those are kind of the two major options in that case.
The next question is from Anna. She asks, why is it so common that we feel such deep fatigue during the process of antidepressant tapering?
Great question. Yeah. I think there's no one simple answer, but I think there's lots of things that are going on. I mean, I think it's a very physiologically demanding process. You're sort of running a marathon with your nerve cells. There's a lot demanded of them. They've got to, change their receptor sensitivity. There's genetic changes going on. There's a whole series of things. I also think there's a great diminishment of sleep quality in withdrawal generally. Most people wake up feeling exhausted because their sleep is being disrupted, and because they're getting less restorative sleep, that's probably why they're so fatigued. So I'm sure it's a variety of different things, and it could be different for different people, and it varies about the drug, but probably to do with the kind of physical exertion of withdrawal and a change in sleep quality are probably the main reason.
The next question is pretty general, but I always think it's important to hold space and cover it. Can we cover some of the more common withdrawal symptoms?
So the answer is there's a lot. It a bit depends on which drug you're talking about, although there's a lot of commonalities. And I guess because psychiatric drugs and antidepressants affect every bodily system, they don't just affect the brain, they affect the peripheral nervous system, they affect the gut, they affect the hormonal system, they affect the skin. There's no cell in the body that's not affected by psychiatric drugs. And that's why withdrawal effects from them can affect so many, can cause so many different symptoms. So people normally break them up into physical symptoms and psychological symptoms. And they don't mean, psychological symptoms are in your mind. They basically mean, the nervous system is being affected, so you get psychological symptoms. And so common psychological symptoms are low mood, anxiety, obsessional thinking, crying spells, suicidality, panic attacks. And I should say all of those symptoms occur even in people that didn't have those symptoms before they started the drugs. So I've seen people who were put on antidepressants for reasons other than mental health. They were put on it for the menopause, for tinnitus, for pain, and even they develop all the symptoms I've mentioned when they come off the drugs. So I think psychological symptoms are very, very common. I'll highlight one before I forget it, which is akathisia. Akathisia is this sort of restlessness, agitation, terror. People describe it often in the morning as you're waking, this kind of incredible terror that I've had a taste of. It was, the most disturbing experience of my life, definitely. It's generally recognized by doctors as occurring with long-term antipsychotic use, but it can be caused by coming off almost any psychiatric drug too quickly. And it's one of the most distressing, disturbing symptoms that makes people often think about taking their lives because it is just so unbearable to experience. So those are sort of the psychological symptoms. And then the physical symptoms, there's a list of about 80 symptoms. Occasionally I hear a new one. You can get gut symptoms, diarrhea, constipation, vomiting, pain. You can get headache, dizziness. People can get a rapidly beating heartbeat and arrhythmia. People can get muscle cramps, muscle pain. They can get sensitivity to light, to sound, to touch. They can get vertigo, dizziness, I've said. I'm trying to think what I've heard recently. I've covered a lot of them. So, I mean, almost every organ system is affected. So that can make it very confusing for patients and for doctors. They walk in, they say they've got muscle cramps and pains, and doctors say, how can a drug cause that? They think either the person is psychosomatic, they diagnose things like functional neurological disorder, they send people for brain scans, they think about multiple sclerosis, they think about strokes. I've seen, 24 different diagnoses that doctors can apply to these sort of symptoms because they have never heard of these things. The education on psychiatric drug withdrawal in medical education is close to zero.
I'd like to know why doctors don't believe in withdrawal symptoms. And I'm also just going to pair on that really quickly, because this is reference to the JAMA article. How can research come out today that says withdrawal symptoms don't exist?
So, I mean, this is sort of more, this is a scientific question, but it's also sort of a political question. Okay, I've been given a 5-minute warning, so I won't go in forever. This is a favorite topic of mine. In some ways, it's quite simple where this comes from. So originally, when the drug manufacturers put their drugs on the market, they did 8 to 12-week studies to get their drugs approved. And after the studies were done, they stopped the drugs and some of them measured withdrawal effects. And they found that for most people who'd been on antidepressants for 8 to 12 weeks, mostly they had only mild and brief withdrawal effects on stopping. That's true. A minority of people already had quite severe symptoms on stopping drugs like Effexor after just 8 weeks. But it's true to say mostly mild and brief symptoms after stopping. They published a bunch of papers saying that, and guidelines took up those papers and they described withdrawal effects as being brief and mild. And so when your local psychiatrist or general practitioner looks at the guidelines or are taught it in medical school, they're taught withdrawal effects are brief and mild. And doctors, of course, pay a lot of attention to what they're taught and what's in guidelines. And so, that's why they think that withdrawal effects are not a big deal. And when you come into their offices or to the hospital or the emergency department and say, come off my drug, I've never felt this sick before, I want to die. Doctors they look at their textbook, they say, brief and mild, that's not this. It must be something else. It must be a mental illness or a physical health problem. And that is a bit perpetuated. Talking about, there's been a recent paper put out in JAMA Psychiatry by some researchers in the UK, where they basically gone and looked at the same studies again, these 8 to 12-week studies. They've put together it with more modern techniques, meta-analysis, and they've said, lo and behold, there's not much of a withdrawal syndrome. And they've put it out in a very prominent journal, and a lot of doctors are saying, oh, it's just what we thought before. And of course, the trick is the longer that you use an antidepressant or a psychiatric drug, the more your brain gets used to it, and the harder it is to stop, the more withdrawal effects you get. So looking at someone after 8 weeks of use doesn't tell you anything about someone who's used the drug for 8 years. We know in America, there are tens of millions of people that have used these drugs for years or decades. The line that I often repeat is, it's a bit like testing if a car is safe by crashing it into a wall at 5 miles an hour and ignoring the fact that people are driving around on the highways at 60 miles an hour. So if you've been on Effexor for 10 years, your risk of withdrawal effects is extremely high. They're very likely to be severe. And that's, very much unrelated to the 8-week studies that most studies are done on. And that's why doctors are sort of taught on the wrong end of the spectrum. And that's what's caused so much trouble, I think, for patients.
Can Dr. Horowitz give his views on when he thinks one should continue to hold versus move forward with the taper following a difficult, or choose the word horrible, withdrawal experience and having to reinstate?
There's sort of not a one-size-fits-all answer, but I'll do my best to give that answer, which is, I think you need to be a lot better before you start tapering again. Again, everyone's circumstances are a bit different. And so the rule of thumb that I use in my clinic, and it's very arbitrary, I realize, but I get people to rate their symptoms out of 10, where 10 means awful, unbearable, I can't, live, and 0 means, almost no symptoms, I'm dancing in the sunshine. I think people should be back down to a 3 out of 10 or less before they start again, with the idea being you want enough headroom that if you start tapering again, there's lots of room for things to get a bit worse if they do. Whereas if you're at 8 out of 10 and you can barely hang on, you don't want to add in further complications. Some people start again at 4 or 5 or 6 out of 10 because they're very keen to get off their drugs. Some people want to wait until they're 1 or 2 out of 10 before they start. So it's a bit different, but I guess my answer is you should feel quite a lot better before you add on trouble. And I guess the analogy that I would use, it's sort of like you break your leg, in kickboxing, you should wait until it's quite, pretty much healed before you start going back to kickboxing, because chances are you're going to If you cause trouble, you want to have a good solid leg there before you inflict a hit on it.
Thank you all for coming in. I really appreciate it. This is like one of my favorite hours of work every month, is actually getting in here and being able to interact with all of you, and with Mark, who's lovely and has so much wisdom to share with us all. And we all have our own experiences, and we're creating, despite, what's maybe being said about whether or not withdrawal symptoms exist, we exist. And we had these experiences, and no one can take that away from us. But by speaking, by being open, by engaging with our content, with engaging with other online communities and resources, we help make sure that we avoid the erasure of our experience. And I just want to thank you all for spending an hour with us, because it's a commitment. And then be sure to send this to someone who might need to hear it or is interested in learning about it from our YouTube channels or from our socials. I can't wait to see you guys next month. All right. Bye-bye.
Thanks, Emma. Thanks everyone for all your questions.